This most people here are what, first and second year?
Is your for the second year?
Okay.
Yeah, first second.
Mostly because there's a mix.
It's probably a mix. I know like up there is first, and then second or here. But I see a couple of kids from our class here too. I would just make sure that you want to just go over the anatomy a little bit.
Yeah, I'm gonna do that a lot. Actually.
Yeah, because okay. This recording. I think
It's a stop recording. So
it's just yeah, I think it is. Right? Just make sure you. Yeah, it's definitely recording. Sharing.
Now it's recording now?
Yeah.
Okay.
Yeah, it should be audio. Yeah.
I'll lose my voice halfway through. All right. So good evening, everyone. My name is Charlie Gatt. I'm the chairman and program director of the Department of Orthopedic Surgery here at the medical school. And I actually graduated from this medical school in 1989. And I give this lecture every year, usually to anatomy. And I remember sitting in these seats, although it was in the other lecture hall, doing anatomy. And Joe Letty, who was one of the senior members of the practice that I'm in right now, came and gave the clinical correlations lecture on hand injuries. And I remember sitting there like after doing, a month and a half or 2 months of anatomy. And he came in and started showing all these great x-rays and telling all these great stories about how he could make diagnoses and treat different injuries based on knowing the anatomy. And that's when, to me, like everything clicked. Like instead of just going up to the anatomy lab and reading books and looking at anatomy, found out, well, this is why you need to know this kind of stuff. And so hopefully today, when we go over knee anatomy, I'll be able to have the same impact on all of you and understand that anatomy lab is very important. And in my career, I've kind of pursued a career as a clinician scientist, and I'm working on a tissue engineered device for replacement of the knee meniscus. And as a consequence, I actually do go back to, courses like biochemistry and biomechanics and things like that for the research that we're doing. So as painful as it is to sit through the first years of medical school, you can't wait to get into the hospital and take care of patients. Depending on your career path, almost a lot of what you're learning comes into play. And again, I'll try to show that a little bit to you today. So that's not it. I make this thing move forward. I have to click that every time. So this one clicks in. There it goes. All right. So as far as orthopedics, everyone thinks of orthopedics as bones, right? Broken bones and things like that. And it is, but as you see, it's all musculoskeletal soft tissue. But when you think of the knee joint, basically it's made up of 4 bones: the femur, the tibia, the fibula, and the patella. The patella is actually a sesamoid bone. Let me go back. There we go. It's a bone that's encased in a tendon. So the patella is in the quadriceps mechanism that then becomes the patellar tendon, but it does have articular cartilage on the deep side. So, and it forms part of the knee joint. The fib joint is another relatively important joint because it involves, has an impact on the ankle and rotation of the lower leg, but those are the 4 main bones. And then, so if we look at the patellofemoral joint, it's kind of an interesting joint because number one, it's the most common reason that patients come to an orthopedic office with knee problems is related to patellofemoral pain. So as much as people like to talk about ACLs and meniscal tears and arthritis, patellofemoral pain is the thing that I see as a sports medicine specialist on a very regular basis. So as I said, the patella is encased in the quadriceps mechanism, and it's kind of held in place by the retinaculum, the medial and the lateral retinaculum. Now, the lateral retinaculum tends to be stronger and tighter than the medial retinaculum, and the vastus lateralis, which comes in on the lateral side of the patella, tends to be a little stronger and tighter than the medialis. So most of the problems that we see in patellofemoral pain are related to something called patellar maltracting. So if somebody asks you, which way does the patella move medial or laterally, by understanding the anatomy, you're going to know that it tends to track towards the lateral side. And this is an X-ray called a merchant view. And you can see in this particular X-ray, the patella is tilted and shifted to the lateral side. So this patient is complaining of anterior knee pain. Now, when I was a medical student, and even when I was an orthopedic resident, nobody ever discussed what's called the medial patellofemoral ligament, the ligament that goes from the medial side of the patella down to the medial epicondyle of the femur for the most part. And so there was no operation called a medial patellofemoral ligament reconstruction. But throughout my career, that has now become one of the most common operations for treating patellofemoral instability. So again, it's a ligament that goes from the upper 2/3 of the patella and then attaches at a level of where the medial epicondyle and the adductor tubercle kind of join together. So, you know, I always used to think that anatomy is something that it's fixed, right? It's never going to change. But here I am after being in practice for about 24 years now. I'll show you some other ligaments that have come onto the scene that were not there when I was in your seat as a medical student. There we go. And then there's the meniscus. So the meniscus to me is very interesting because we're doing a lot of research on a tissue engineered meniscus replacement. But the menisci, there's a medial meniscus and a lateral meniscus. And what you'll see is that the lateral meniscus provides a greater amount of coverage over the tibia than does the medial meniscus. Although the medial meniscus is much more commonly torn than the lateral meniscus. So the meniscus work by what's called hoop stress. They convert axial loads, so the compression in the knee joint is converted to tensile loads in circumferential fibers of meniscus. So it's an important shock absorber of the knee joint. And so when you lose your meniscus, it actually predisposes you to arthritis. Now, a long time ago, again, before my time, people thought the menisci were almost vestigial organs, like you didn't need them. And at one point, they were taking the entire meniscus out, the medial meniscus, and using it as a graft to reconstruct the ACL. And then there was a guy named John Smiley, who was one of the most famous orthopedic surgeons, and he had a tool called the Smiley knife, which was technically a meniscotome, and it was a knife that you would use to carve out the entire meniscus. And what Dr. Smiley taught the world was that if you don't remove the entire meniscus, it won't grow back. Well, that was wrong. The meniscus never grew back, and all those patients that had total meniscectomies ended up with knee replacements later on in life. It was essentially a guarantee that was going to happen. Now, as you'll see, we do everything we can to preserve the meniscus, and actually ACL reconstructions are done in an effort to protect the menisci so that people don't go on to arthritis. So the meniscus, you know, what you have to understand about the meniscus is that only the outer 1/3 of the meniscus has blood supply. The inner 2/3 don't have blood supply. So when I talk about repairing a meniscus tear, the only tears that we can really technically repair are longitudinal tears in the periphery of the meniscus where there's blood supply. I can sew anything back together, but if it doesn't have blood supply, it's not going to heal. So eventually it's going to re-tear, right? So if I have an inner margin tear here, I'm going to tell the patient the best thing to do is take that out and leave as much healthy meniscus behind. And here's just a classic picture of the capillaries in the outer 1/3 of the meniscus. And you can see the meniscus increases contact area between the round femur and the flat tibia. So by increasing contact area, mechanically, that decreases contact stresses. So that's why the meniscus is so important. And it kind of works as the hoops in a barrel, because the meniscus isn't a complete ring. It's fixed to the tibia at the posterior horn and the anterior horn, but that incomplete ring mounted to the tibia allows the round femur to press down on the tibia, but then try to extrude the meniscus out of the knee. But since it won't extrude out of the knee, it generates tensile forces in its fibers, and that's how it functions as a shock absorber of the knee. So all these things are important. And so talk about how biomechanics plays a role in what I do today in terms of teaching the residents about how much meniscus to remove, what's safe to remove, and even my research, understanding the longitude, the importance of the peripheral rim of the meniscus is important in how you manage it. If you took a knife and just cut across the meniscus like this, but left the whole thing in place, it would be as if you did a total meniscectomy. because you broke the hoop, right? If I took this barrel, let me go back again, sorry. But if I took the hoops on the barrel and just cut them here, the barrel would fall apart. But if I just took out part of the ring, but left the circumference of it intact, it still, for the most part, does its job. So again, that's why preserving meniscal tissue is so important. And then there's the ligaments. So I like to keep things, when I talk about the ligaments, you can get very complex and very esoteric, but for the most part, what you need to know is there's 4 ligaments in the knee. There's the anterior cruciate ligament and the posterior cruciate ligament. They're in the center of the knee in the intercostal notch. They are named for their attachment onto the tibia. So if you don't know which one is which, you look at where it attaches to the tibia. The ACL attaches anteriorly, the PCL attaches posteriorly. The ACL attaches right on top of the femur in the anterior one of the tibia, in the anterior 1/3 of the tibia, and it goes to the posterolateral aspect of the femur, whereas the PCL comes from the anterior medial femoral condyle and goes to the back of the tibia, and it actually attaches 1 centimeter below the joint line. And that's important to know because we can't sew or repair cruciate ligaments. We have to reconstruct them. And how do you reconstruct them? You have to reconstruct normal anatomy. If you think that the PCL attaches onto the top of the tibia and you put your tunnel in the tibia coming out on top, you have abnormal anatomy, it's not going to work. And ACL reconstruction over the last 10 to 15 years has really focused on a more anatomic reconstruction that we've done in the past. And then you have your collateral ligament. So on the inner side of the knee, you have your big fat medial collateral ligament, which is it prevents the knee from deforming into valgus. And it's important that that ligament is big and strong, because where do people get hit when they play football or soccer, or somebody rolls into their knee? They hit it on the outside of the knee, right? So the MCL has to be strong, and it is. Whereas a lateral collateral ligament is a much smaller ligament that goes from the femur to the fibula. And that, how many times do people get hit on the inside of the knee? Really not very often. Who tears a lateral collateral ligament? Basically in sports, it's wrestlers, because wrestlers put their knee in a weird position like this, and then their opponent pushes down on it, and it's a varus force to the knee. So the LCL prevents varus deformity of the knee. But again, it's not as strong a ligament. It's probably, when you look at it, it's the size of a shoestring or something like that. Whereas the MCL is probably 2 to even 3 centimeters broad. Now there's a deep MCL and a superficial MCL and things like that. You don't really need to know that much about all of that. But that said, I will tell you that again, in my medical lifetime, 2 more ligaments have been named in the knee that weren't there when I was sitting in your seats. So I just find this kind of somewhat interesting, but the popliteal ligament. So the popliteus muscle goes from the back of the tibia up to the lateral femoral condyle, attaches relatively close to the LCL attachment. But there's a ligament that goes from the bottom surface of the popliteal ligament and attaches onto the fibular head, or back from the bottom of the popliteus and attaches onto the fibular head. And so I think it was when I was a fellow, when it first started being described, and they said, this is a new ligament that's never been described, and it's really going to play an important role in posterolateral rotatory instability to me, because that's kind of a difficult problem to solve. Interestingly, after the person who said, "Oh, I found this new ligament," somebody went back to really old versions of Gray's Anatomy, like, that weren't like scanned, and found out that in the original version of Gray's Anatomy, there was a popliteal ligament, and then all of a sudden the editors just took it out for some strange reason. Everybody forgot about it, and then they found it again. So it really wasn't a discovery. It was just something that got lost in editing. But then, again, this goes back probably about 10 or 11 years ago. All of a sudden, this was actually on the Wall Street Journal and the New York Times, new knee ligament discovered. And this was the anterolateral ligament, which is a ligament that goes from the lateral femoral condyle down to just posterior to Gerdy's tubercle, where the Gerdy's tubercle is where the iliotibial band attaches. And that's a ligament that, again, controls rotation of the knee. Because if you think of what the cruciate ligaments do, everyone thinks of the ACL as preventing the tibia from coming out forward under the knee, and the PCL preventing the tibia from coming out backwards under the knee. But I can tell you, it's not one plane motion. The knee is kind of it's a hinge joint, but the tibia also internally, externally rotates on the femur. And these other ligaments, like the popliteal ligament and the anterolateral ligament, play a role in controlling the rotation. So as we look at to find why some patients don't do well with ACL reconstruction or don't do well with a PCL reconstruction and a posterolateral corner reconstruction, is it because we may not be paying enough attention to these more subtle ligaments that can make a big difference in knee injuries and have more rotatory stability than translational stability, okay? Hopefully that makes sense. But again, I find this just interesting. You think anatomy is anatomy, and you're not going to find out anything new. So who knows, 20 years from now, you may stand up, give a lecture to medical students and talk about a new ligament that I never even heard about or that you never even heard about. And then the musculature. So the quadriceps muscle, obviously, there's the four muscles, the rectus femoris, the vastus medialis, lateralis, and intermedius. And they kind of coalesce to form the quadriceps tendon. And as I said, the patella is a bone contained inside that tendon as a sesamoid and then becomes a patella tendon. What is the reason that the patella is there? The reason is that your extensor mechanism extends your knee, right? So if the tendon was right on the surface of the femur and the tibia, the moment arm, which again goes back to physics and biomechanics, would be so close to the center of rotation that it would require a lot of muscular force. The patella pulls the tendon or pushes the tendon anteriorly, so the distance from the patella to the center of rotation increases the moment arm, so your quadriceps mechanism works more efficiently, and that's the reason you have a sesamoid bone. Now, one of the things about muscle strain injuries, when you strain muscles, you strain muscles most commonly that span two joints, all right? So if you look at the muscles of the quadriceps, the rectus femoris muscle is the only muscle that spans two joints because it comes off of your pelvis, it comes off of the just superior to the acetabulum and off of the anterior inferior iliac spine. It crosses the hip joint and then becomes part of the quadriceps and then crosses the knee joint. So if somebody asked you of the four muscles of the quadriceps, which muscle is strained the most commonly, it would be the rectus femoris. You would know that because it crosses two joints. On the posterior aspect of the knee, you have your hamstring tendons. You have your biceps femoris, which is laterally, and then you have your big semitendinosus and semimembranosus medially. You also have a kind of another described hamstring called the gracilis, which is a little bit of an internal rotator and a flexor of the knee. You have your sartorius, which kind of crosses the front of the knee, and then you have your gastrocnemius and the popliteus tendon. I explained the popliteus is an interesting muscle because the muscle belly is distal and the tendon goes proximal. It's almost like it's an upside down muscle. And the gastrocnemius is another muscle that gets strained. So your calf muscle is made up of which two muscles? The gastroc and the soleus, right? The soleus comes off the back of the tibia and crosses the ankle joint. The gastroc comes off the back of the femur and crosses the knee joint and the ankle joint. So again, with the question of the two, when someone strains their calf muscle, which is what a layperson says, but as a physician, you know which muscle they strain. They strain their gastroc. They don't strain their soleus. It almost never happens if you have an isolated soleus strain. And medial gastroc strains are so common that they've given sports names like tennis knee, because middle-aged guys who are playing tennis and are out of shape pull their calf muscle, and what they really do is they strain the medial head of their gastroc. So that's what a tennis knee is. And then we have the neurovascular supply. So in the back of the knee, we have the sciatic nerve, which then splits off into the tibial nerve, which continues down the back of the leg, and then we have the peroneal nerve. The peroneal nerve is probably one of the most commonly talked about nerves in orthopedic surgery. Number one, it wraps around your fibular neck, right? So you'll see people that have sustained a direct blow to the outside of the leg, or they sustain a fracture, where the fracture goes right through the fibular neck, and now they can't dorsiflex their ankle or evert their ankle because their peroneal nerve has been damaged. You'll see this when we talk about high energy knee dislocations. We also get a lot of peroneal nerve injuries. The saphenous nerve comes down the front the anterior medial side of the knee. And there's one branch of the saphenous nerve called the infrapatellar branch of the saphenous nerve. So it comes down, the saphenous nerve is coming down immediately, and then the saphenous, the infrapatellar branch crosses across the knee and gives you sensation over the tibial tubercle and just lateral to the tibial tubercle. Now, why is that important? That's important because the most common surgical approach to the knee is a midline longitudinal incision. So if I do a patella tendon harvest for an ACL reconstruction, if I do a knee replacement, if I repair a tibial plateau, I'm going to make a midline longitudinal incision. Well, 6 weeks after surgery, the patients say, hey doc, the outer side of my knee is numb. Why is that? And I'm going to tell them because I cut the infrapatellar branch of your saphenous nerve. Because it's a small nerve, I can't see it as I'm making that dissection, and it's just part of the operation. I know they're going to be numb. So most of the time I remember to tell patients that, but not all the time. Now that the sensation kind of grows back, but not 100%. So again, understanding your anatomy will explain to you why the lateral side of the knee is numb when your incision is more on the midline or the medial side of the knee, okay? And then we have the popliteal artery, which comes down the back of the knee, and there's a trifurcation where it trifurcates into the posterior tibial artery, anterior tibial artery, and the peroneal artery. Now, this trifurcation is tethered rather tightly in the back part of the knee, just below the just at the metaphysis of the proximal tibia. Why is that important? Because one of the traumatic injuries that we see in the knee is a bumper strike injury. So if you think about a car bumper, it's going to hit a lot of people right around the just below the knee joint. And so what they get is these high energy fractures of the tibial metaphysis. So what do you have to worry about? You have to worry about a vascular injury, because if the tibia displaces dramatically at the time of the injury, and that's tethered tightly, you can tear your one of your 3 branches or tear it just proximal to the trifurcation, and that's a problem. When the orthopedic residents are drilling pins right through the proximal tibia for like an external fixator, they have to be careful that that pin doesn't go too deep, because what's right behind the tibia, the popliteal artery, and the trifurcation, and it doesn't have a lot of room to move around. So understanding this nervous anatomy is really important in terms of our surgical approaches. But the truth of the matter is the utilitarian approach to the knee is a midline anterior approach. So you're not really going to see many of these nerves and vessels unless you're working in the back of the knee, which is not really that common. So that's kind of the overview of anatomy that should help you understand some of the clinical problems that we see. So I'm going to talk first about patellofemoral pain, because it is the most common thing that I see in my sports medicine practice. I call it the back pain of sports medicine. Nobody likes patellofemoral pain because there's not a lot of great surgical options for it, and the patients tend to struggle a little bit with getting better. It's not like we have a quick fix to it, but it is what we see the most. So typically patients come in, they have an insidious onset. They say, doc, I have this pain in the front of my knee. You ask them where it is, they can't point to one spot. They just kind of grab the kneecap and kind of rub all over the front and say, it hurts here. They say things like, it hurts when I climb upstairs. It hurts when I'm sitting for a long time. It hurts when I get up out of a low seat, or when I get up off of the floor. And why is that? Why does that happen? Because again, it goes back to what we talked about with patella maltracting. As you're going up the stairs or down the stairs, your quads are firing. And if you have an element of patella maltracting, your kneecap is tracking laterally, which probably leads to uneven pressure on the articular cartilage between the patella and the femur. And we believe physiologically that's a source of pain, although we're not 100% sure. And every now and then patients will say, I feel like my knee gives out on me. I feel like it's in a buckle. And probably what's happening in some of those cases, but not all, is the patella is subluxating or shifting enough laterally that the body says, wow, my patella is going to dislocate, and the muscles turn off, and then they feel like their knee gives out or buckles on them. But also pain can be a source of instability. In other words, you can have so much pain that your muscles just kind of shut off for a brief second, and you feel like your knee is going to give out. It's not really instability because there's no damage to any ligaments. On physical examination, when I examine them, I can actually palpate the 2 facets of the patella, the medial facet and the lateral facet. If I put kind of dig my fingers underneath the medial facet of the patella and underneath the lateral facet, I can tell if they hurt there. I can have them flex and extend their knee and see if there's signs of patellofemoral crepiness. Now, a lot of patients come into my office and they say, doc, listen to my knee, it's like all creaky, and they're afraid they're getting arthritis. I tell them, does it hurt? And they say no, and I say, then don't worry about it. What is it? It's probably an element of, maltracking of the patella. It could be softening of the articular cartilage, but I see 17-year-old girls come in with crepitus under the patellofemoral joint. They don't have arthritis, and they're not getting arthritis. It's just a softening of the cartilage that leads to this sound that's a little disconcerting to people. Unfortunately, a lot of people with patellofemoral pain are overweight, significantly overweight. And why, it's obvious why that's a problem. The more weight they have above their knee, the greater the contact forces between the bones are. So it's going to put more stress on the articular cartilage. And then one of the things we look for is called the lateral patella apprehension sign, where we flex the knee about 20 degrees. And the reason we flex the knee 20 degrees is because by doing that, the patella gets engaged in the femoral trochlea, in the groove of the femur, and then we press the patella laterally, and if they wince or kind of tighten up, they know that feeling that their patella is going to jump off the lateral side of the knee, and that's a lateral patella apprehension sign. People only have lateral patella apprehension signs. They don't have medial patella apprehension signs because the patella doesn't dislocate or subluxate medially, right? Because we know that the lateral structures are tighter and stronger than the medial, and the only people who dislocate their patella medially, which is excessively rare, is when people do really bad surgery on a knee. Then you can have a medial patella dislocation. I've only seen one in my entire career. Luckily, I didn't do the operation. And so people talk a lot about the Q angle. So why, I'll tell you one thing, is that patellofemoral pain is more common in women than it is in men. Why do you think that is? Well, women's knees are more valgus. They're more knock knee than men, right? So that's what we talk about with the Q angle. So if you think about the Q angle, if you were to think of the quadriceps as a rope, it comes from the hip, goes down to the patella, and then down to the tibial tubercle. So if you're excessively knock-kneed, then your Q angle is greater. And think about pulling out a rope. If you had a rope that had a 17-degree angle in it, and you try to pull it straight, well, if you pull the rope straight, the patella is going to move laterally, right? So the greater the Q angle, the more lateral force there is on the patella. So again, understanding a lot of these things may have an impact on our surgical planning, as you'll see. And so radiographs. Now, X-rays are two-dimensional pictures of three-dimensional objects, right? So when I want to see, imagine what something looks like in 3 dimensions, I have to have 2 orthogonal pictures of a bone, right? Because I can look at this X-ray here, which is a standing AP of the knee, and unless somebody comes in with what I think is a badly broken bone, I always get a standing AP. I don't get a supine AP where they're lying down, because their weight is going to have an impact on the joint space. So I want to know, let's say, do they have arthritis? If this person is standing and they have medial compartment arthritis, we'll see narrowing of the joint space there. But if I do it lying down, you may not appreciate that. So when you all get into your family medicine rotations and ER rotations, encourage your doctors to get standing AP views rather than supines, and you'll look like a star. But the standing AP view doesn't, I don't know if this tibia is sitting anterior to the femur, posterior to the femur, or right underneath it. So if I get a lateral view, I can tell them my alignment is perfect, right? Now I can't see my patella on the AP view. It's superimposed on the femur. So number one, I haven't really seen my patella yet. I can see it on the lateral view, but all I can tell is that my patella is sitting about where it belongs in relation to the femur. There's actually a fixed distance from the inferior pole of the patella to the tibial tubercle. That's the length of your patellar tendon. But I don't know if this patella is medial or lateral. So then I get a merchant view, which is also referred to as a skyline view sometimes. And here I can see that my patella tilts and subluxates laterally a little bit, again, indicating patella maltracking. I can't tell this on this X-ray, and this X-ray doesn't tell me that either. So you need orthogonal X-rays of everything you do. If you do the shoulder, you need orthogonal X-rays. If you do the neck, you need an AP and a lateral view. And always remember, these are two-dimensional pictures of three-dimensional objects. Yeah.
For the merchant, is the knee bent in that?
Yeah. So yes, that's a good question. So the way they do a merchant view is the knee is flexed about 30 or 40 degrees. So it's kind of bent like this. The patient's lying on their back. The X-ray plate is down sitting on the foot, and the X-ray beam goes through like that. Okay. That's a merchant view. And so what they order in the emergency room is a skyline view because it's really easy. In the skyline view, the knee is hyperflexed. So they just hyperflex the knee like 140 degrees. They put the plate here and they shoot the beam there. But when the knee is flexed 140 degrees, the extensor mechanism is so tight that patella, no matter what you do, the patella is going to sit dead center in the trochlea because there's no way it can go anywhere. But at 30 and 40 degrees, that's where patients are symptomatic. And that's a more physiologic representation of what you want of the patellofemoral joint. So again, if you're trying to know if someone has lateral patella tracking, a skyline view is not going to help you. A merchant view is going to help you. All right. So again, great thing to know in your family medicine. So because with orthopedic surgeons, I have X-ray in my office. So my techs know exactly what to order. And I tell them 1,000 times, they know, I just write knee X-ray and they get me these 3 views. If you on your rotation write knee X-ray and send them to radiology, you're going to get an AP, a lateral, and an oblique of the knee. And an oblique is just kind of halfway in between a lateral and an AP. And to me, I think in my entire career, I've ordered 10 obliques of the knee. So oblique means nothing to me, and I have no idea what's going on with the patellofemoral joint. So if you write a knee X-ray someday, I want you to write on your prescription standing AP, lateral, and merchant, and then everyone will know you know what you're talking about. So treatment. So how are we going to treat patellofemoral pain? And the treatment is 90% of the time patients are going to get better with physical therapy. So what do we need to do to treat these patients? Well, you know the anatomy, so you know what to do. You need to stretch or loosen up the tissues on the outer side of the patella. So the iliotibial band, the vastus lateralis, and the lateral hamstrings, and you need to strengthen the pull on the medial side. So you need to do VMO or vastus medialis oblique strengthening. And where does the VMO activate? Well, the VMO activates in about the last 40 to 30 degrees of knee extension. So if you do straight leg raises, you have a greater activation of the VMO. If you do what's called terminal extension exercises, you have a greater activation of the VMO. So you go from 30 to 0, you get more VMO strengthening selectively. Now, and then you do what are called limited arc. So that's that range from 30 to 0, open and closed chain quads. Open chain exercises mean your foot is not planted on the surface. So a knee extension is an open chain exercise like this. A squat where your foot is planted on the floor, or a leg press where your foot is pressed against the foot plate, that's a closed chain exercise. The difference between open chain exercises and closed chain is open chain has isolated muscle contraction. So this is just my quad. A closed chain exercise has co-contraction. So when I do a squat, even though my quads are the prominent contracting muscle, my hamstrings are also contracting. And that has that's more important when you're talking about other ligament injuries, but they both come in handy. And then, we prescribe non-steroidals not for the anti-inflammatory effects because, even if you look at when you look at the histology of arthritis, again, now looking at your histology course, is there inflammation in the knee? Do you see a lot of white cells in the knee with somebody with osteoarthritis? The answer is no, there isn't. So that's why the term osteoarthritis is a bad term, because there's no inflammation. The right term, and we use it a little bit more in orthopedics, is arthrosis. But the non-steroidals that we prescribe, we're prescribing more for their analgesic effects than their anti-inflammatory effects. Now, if you have rheumatoid arthritis or psoriatic arthritis or any other of the inflammatory or autoimmune arthropathies, then you are looking for anti-inflammatory effects, but you're probably going to take it to the next level, with things like methotrexate or even prednisone and things like that. But you can go with high-dose anti-inflammatories. But you don't see a lot of rheumatoid arthritis, at least in my sports medicine practice. Let's see. So do I normally get an MRI in these? Not often, because again, they haven't really sustained any trauma, and I'm not really looking. There's nothing I'm going to see that often. But every now and then, you'll see like a chondral defect. This person has thinning of the patellar-articular cartilage and a little subchondral edema in the patella. And that may be an explanation for why they're having some of their pain. You can also assess for tendinopathies like patellar tendonitis and quadricep tendonitis as a source of anterior knee pain. But I don't get MRIs that often because they almost always come back negative. But I do get them when patients beg for them because they're convinced there's something in their knee that I can fix surgically, and there is nothing. in the knee that I can fix surgically, and that's why orthopedic surgeons don't like taking care of patellofemoral pain. But sometimes patients don't respond to conservative measures. They do a year of physical therapy, they take medicines, and they're still having a lot of pain. So one of the operations that we can do is called a modified Fulkerson procedure. So this is, I actually did one of these today, but not for patellofemoral pain. But what we do is we do a tibial tubercle osteotomy. We cut the tibial tubercle off, that's the patellotendon attachment, and we move it medially, we swing it medially, and we also cut it in an oblique way so that as we swing the tubercle medially, it moves anteriorly. So by moving my tibial tubercle anteriorly, what am I doing? I'm moving the patellotendon further away from the center of the knee. So I'm also pulling the patella further, I'm pulling it off of the femur a little bit. We're talking like, a millimeter or a few degrees. But by bringing this forward, I decrease my patellofemoral contact forces. So that's one way to cure the pain. And I've also swung the patella medially, or the tubercle medially. I'm just going to go back real quickly to this one. So again, if I do a tibial tubercle osteotomy and I take this tubercle and I'm just exaggerate and bring it way over here, what's my Q angle now? It's 0, right? So that's why we do what's called an anteromedialization of the tibial tubercle. So understanding anatomy is going to explain why that operation works. And then the other kind of extreme case, which is more traumatic, is a patella dislocation. So again, if somebody asks you, someone tells you, I dislocated my patella, you know which way it dislocated. You don't have to ask them because it only goes one way. It only goes laterally, right? So this is an example, you don't see this very often, but this is an example of the patella being dislocated. It usually occurs as somebody's knee is flexed and they're starting to straighten out their knee. It occurs in wrestling, but I've seen people dislocate their patella walking off of a curb. And so they fall to the ground and the knees bent. And it's an easy thing to treat. You just straighten out the leg because now, did I just go back? All day long. It's stuck on the lateral side of the femur, but the extensor mechanism is so tight that you can't push it back. But if you straighten out their leg, it almost will spontaneously pop back into place. And if it doesn't, you just give it a little shove and it'll go back into place. So it's a really easy thing to treat. When they come to the office, they have a large effusion. Sometimes they'll say they hear a pop, and the classic, if someone injures their knee and they feel a pop, everybody thinks it's ACL tear, but people do dislocate their patella. Again, when it comes to your office, even to the emergency room, it's almost already reduced because everybody straightens out their leg, or someone who's at the game or on the field or whatever straightens out the leg and the patella pops back into place. But if you examine them, they're going to have a tender medial retinaculum because if the patella goes laterally, they're going to tear the medial retinaculum or the medial patellofemoral ligament. So the first time that people dislocate their patella, this is an MRI. Here's a torn MPFL, medial patellofemoral ligament. Here's the bone bruises that occur, right? Because imagine this patella is now in proper position or close to proper position, but it was sitting all the way over here. So the medial facet of the patella and the lateral femoral condyle have bone bruises. I don't have to see anything other than those bone bruises, and I know this patient had a patella dislocation. I don't have to see the medial patellofemoral ligament or the medial retinaculum. Those bone bruises tell me what happened. So when I treat them, first time, I put them in a knee immobilizer for comfort, just to allow the effusion to resolve and things like that. I look for loose bodies because this is a relatively traumatic event. As that patella goes off the knee and back into place, you can shear off a big hunk of articular cartilage. And if I look at this MRI and I see a 2-centimeter chondral defect, there's a big piece of cartilage floating around the knee that for a young person, it would be better if I could put it back into place. So for patella dislocations, I do get an MRI because I want to know if they have an osteochondral injury that I can put back into place and hopefully preserve the health of their knee joint. When they become recurrent, when they, if one of you dislocated your patella, I would tell you that there's a greater than 60% chance that you'll redislocate your patella again in the future. So you try to treat it with physical therapy because it does work in a lot of cases, but if it doesn't work, you can either do a medial patellofemoral ligament reconstruction, rebuild that ligament, that tether, or you can do a tibial tubercle osteotomy. They both work relatively well to prevent recurrent dislocations. again, you're either putting a tether on the medial side of the knee, understanding MPFL anatomy, or realigning the tibial tubercle because anatomically they're predisposed to that because they have a high Q angle or whatever the case may be. So that's patellofemoral problems, again, are really common. Meniscal tears, the two most common operations in orthopedic surgery are carpal tunnel release and arthroscopic partial meniscectomy. So removing a torn meniscus is ridiculously common. So when patients come into the office with meniscal tears, they usually have isolated joint line pain. And what you're looking for is mechanical symptoms. If someone comes, they have a dull aching pain on the inner side of my knee, that's arthritis most likely. But if they come in and say, if I twist or bend or squat, I get this really sharp pain on this inside of my knee, or I feel like it's stuck, or I feel like it's catching, or I feel like it locks, that's mechanical symptoms. And the mechanical symptoms are what you're looking for when you're trying to diagnose a meniscal tear. I always tell them, if you think about how you diagnose people, they come in, they give you history, and you have this big differential diagnosis that's this big. And then you take your differential diagnosis and you do a physical exam, and now your differential diagnosis is this big. Then you get x-rays, and now it's this big. And sometimes you need an MRI to narrow it down to what it is. So your history is really important. Taking a good history and a comprehensive history is going to help you a lot in terms of your physical examination. You don't have to examine everything if you start narrowing down your differential. But you can see this in this particular case where this is a meniscus tear, you can see how this meniscus would flip in and out of position in certain positions of the knee, and that's why it would cause mechanical symptoms. Now, interestingly, the inner 2/3 of the meniscus don't even have nerve endings, so there's no pain related to the meniscus, but that meniscus is pulling on the capsule of the knee joint, and it's the capsule where all the nerve endings are. So this gets stuck and pulled in and out of position, you get capsular pain, and that's why you get the joint line pain. So when I examine them, the most common finding and the most reliable finding is actually joint line tenderness, but you do rotational exams, like a McMurray test, where if it's a medial meniscus, I'll varus the knee, I'll internally rotate the tibia, and then flex and extend the knee, and see if I can feel or hear a click or a pop in the knee. And that's a positive McMurray sign. Most times you don't really feel or hear the click, but they'll say that it'll recreate their symptoms. And I would say that's the most common test. You can ask people to duck walk, like get down like a baseball catcher and take a couple of steps, because the majority of meniscus tears occur in the posterior horn of the meniscus, because you're kind of stressing the meniscus more when your knee is flexed. Anterior horn tears they're very, very uncommon and usually asymptomatic. Now, sometimes people come to your office with a locked knee. They'll come into the office and their knee's bent at about 30 degrees and they can't straighten it out. Why can't they straighten it out? Because the meniscus is formed in a way called a bucket handle tear, where the meniscus, instead of being on the periphery of the knee, has now flipped into the intercostal notch. And I'll show you a picture of that in a minute. When people come to you and they tell me my knee's locked in extension, like they say, my knee's stuck straight. Is that a meniscus tear? No. And you'll see why in a minute, but the knee can't lock in extension. If the knee is locked straight, it's usually patellofemoral pain, and the patient has a little bit of psychosomatic issues going on at the same time. But it's not uncommon for people to say that. So here's an example of a locked meniscus. So the patient comes in locked in flexion. So what's the problem? Here is the medial side of the knee. So here's the lateral meniscus, a nice triangle that tapers towards the inside of the knee. Look on the medial side. Where's the triangle? It's over here. It's in the intercostal notch. All right. This is a classic orthopedic test question. I don't know if they ask it on your boards, but here's the posterior cruciate ligament, and here's another structure that looks like another PCL. They call that the double PCL sign. The double PCL sign is the meniscus, the medial meniscus, stuck in the intercostal notch. So if you look at this picture, which is my arthroscopic picture, here's the medial femoral condyle, here's the medial meniscus, and the medial tibial plateau is down here. So why can't that knee straighten out? Because this big hunk of meniscus that's in the way. Until you move this meniscus from here back to here, that knee's never going to straighten out. So if a young person comes in with this injury, I don't call that an orthopedic emergency. There's really not too many emergencies in orthopedic surgery, but I call that an orthopedic urgency. I'm going to get this patient to the OR in the next couple of days. I'm going to put that meniscus back to where it belongs. Arthroscopically, I'm going to sew it back together. Because can this meniscus tear heal? Yes, because the tear is in the outer 1/3 of the meniscus, and that's where blood supply is. But if this person walks around on this meniscus for 6 weeks and beats the hell out of it, by the time I get in there and put it back, it's gonna look like crab meat, it's all shredded, and it's not gonna serve any purpose anyway. So that's why this is what I call an orthopedic urgency. I don't really believe in too many emergencies in orthopedics. So the most common operation is a partial meniscectomy. Now here's a tear. This is a classic, 40-year-old guy who plays recreational basketball. He has mechanical symptoms, and here's his tear. And you can see that this tear is in the inner 2/3 of the meniscus. It's not really a longitudinal type tear, but you can see why this guy would have symptoms. Now here is a picture post-meniscectomy. It looks like he has a lot of meniscus taken out, and he does have a fair amount of meniscus taken out. But what's most important is that the peripheral rim of the meniscus is completely intact. It hasn't been violated. And that outer 1/3 of the meniscus provides the most load sharing capability. So as long as I preserve this guy's going to do okay. And believe it or not, this is a patient of mine from 20 years ago in my practice. And I've seen this guy about 5 years ago. So 15 years later, and even with this amount of meniscus removed, he doesn't have a lot of arthritis because the peripheral rim of the meniscus remained intact. Now here's a case of a young, this guy was 17 years old and played ice hockey. And here's his longitudinal tear of the meniscus right at the meniscocapsular junction. So if I took that meniscus tear out, what do you think would happen to him in 15 years? His knee would be ready probably for a partial knee replacement because he's lost the entire meniscus. He doesn't have that peripheral rim. And so he's going to lose his stress distribution, and his articular cartilage is going to wear away faster. So I can sew this. These are called meniscus arrows, which we don't really use anymore. But I can sew that meniscus back together. It's got peripheral blood supply. That meniscus healed. He went on to play more hockey and never had any trouble with his knee. So number one, I got rid of his pain because he had the meniscus tear that was causing him pain. But number two, I preserved the health of his knee by saving his meniscal tissue. So meniscus is really important. As I said, not that long ago, the meniscus was considered a vestigial organ. The medial meniscus, and again, going back to biomechanics, if you think of the ACL as the primary stabilizer of the knee, from preventing the tibia from coming out from underneath the femur, the posterior horn of the medial meniscus is a secondary stabilizer. Now, why is that important? Let's say somebody tears their ACL and doesn't have surgery. Within 5 to 10 years, they're going to have a posterior horn medial meniscus tear. Why is that? Because we know the posterior horn medial meniscus is a secondary stabilizer of the knee. So once you lose your ACL, holding your tibia underneath the femur, the next thing is your medial meniscus trying like hell to hold it, to stop it from sliding forward, but eventually you tear it. So, that's why another reason why you'll see medial meniscus tears. If someone has a chronic ACL insufficiency and they get a meniscus tear, it's going to be a medial meniscus tear. When we talk about ACLs, I'll tell you about the triad and why that's a little different. And then the other thing that we're going to see is extensor mechanism injuries. So quad tendon ruptures, patella fractures, and patella tendon ruptures. If I look at this x-ray, what's wrong with this picture? The patella is too high, so that's patella alta, right? So if the patella is too high, why is that? Because the patella tendon is ruptured, right? The tendon that goes usually from the inferior pole of the patella to the tibia tubercle, but almost always tears off right at the bottom of the patella, and this person can't extend their knee. They've lost their extensor mechanism. On the contrary, if this patella is sitting down here in a patella baja position, it's a quadriceps rupture. Patella tendon ruptures occur in young athletes. Quad ruptures occur in old guys like me when they're going up and down the stairs. It tends to be a little bit more of a degenerative problem. And then patella fractures, if you have a longitudinal fracture in the patella that goes up and down like that, their extensor mechanism is still intact. That can happen from a direct blow on the knee. But if they have a transverse patella fracture that goes right across the middle, now they can't extend their knee because, again, they've disrupted the connection between the quad tendon and the patella tendon. All of these injuries require surgical repair. They don't heal without any cast or any breaks or anything like that. Then we get to ligament injuries. So again, understanding the anatomy of the ligaments, we have the MCL, LCL. The MCL prevents valgus stress to the knee. The LCL prevents varus deformity of the knee. The ACL prevents the tibia from coming out forward. The PCL prevents the tibia from going backwards. You do get isolated injuries. Probably the most common isolated injury is going to be an MCL sprain because people get hit on the outside of the knee. And then you have, but a lot of times we see combined injuries. So ACL, MCL is very common. PCL, LCL is very common, or is a somewhat common combination. So a lot of these injuries are combined because, again, the injuries to the knee are not purely translational. They're a combination of translation and rotation, and that's why you'll tear more than one ligament. So if someone comes in and says, I was playing football and somebody ran into the outside of my knee and I felt a pop on the inside of my knee, and you examine them, you want to find out that they have, you can press on where the MCL attaches. So the first thing to do is press on the medial epicondyle of femur and then the medial tibial plateau, because those are two attachment sites for the superficial MCL. And it's actually a little important to know if it was a proximal or distal injury. But those are the sites that are the most common. And then you want to see how much does the knee open to valgus stress. If they open a little bit, like you stress them and then you feel the bones of the femur and tibia separate medially, and it opens a little bit, that's a grade 1 sprain. If they open a medium amount, that's a grade 2. And they open a lot, then you call it a grade 3 sprain. Now what I do is I do valgus stress at both 0 degrees and at 20 degrees of knee flexion. And why is that? At 0 degrees or full extension of the knee, both your MCL and your posterior capsule are tight. So if somebody's knee opens to valgus in 0 degrees or full extension, I know it's a really bad grade 3 MCL sprain, because not only have they torn their MCL, which is right here, but the tear has extended around the back of the knee into the posteromedial capsule. There's part of that capsule is called the posterior oblique ligament. And again, you get into a lot of esoterics about the anatomy. But if they open in 0, it's automatically grade 3. What if they don't open in 0, but they open at 20 degrees of knee flexion, and I've already relaxed their posterior capsule by flexing their knee 20 degrees. So now I'm isolating the MCL, and then I can tell if it's an isolated MCL sprain, and that's usually going to be a grade 1 or a grade 2. Why is that important? Well, it's important from an anatomy standpoint, but it's important for the coach, because the coach doesn't care about the anatomy. The coach wants to know, when's that guy going to be back on the field? And a grade 3 MCL is going to take 6 to 8 weeks to get better. A grade 1 or grade 2 MCL sprain can be a week to a 3-week injury. So my job as a sports medicine doctor is to, number 1, take care of the patient, and number 2, keep the coach happy by knowing when his athlete's going to be back in the field. And sometimes that can get a little tough if the coaches are uptight, which most of them are. The other common, I want to talk a little bit more about ACL tears. So the classic ACL tear is a non-contact injury. The majority of ACL injuries are non-contact. So even when you take your test and they talk about the terrible triad, which is an ACL, an MCL, and a medial meniscus tear, that is not the most common injury. They always show you the picture of the football player jamming his shoulder pad into the guy's knee, and you see those injuries. But this is the most common ACL tear. A female who has a glance and cuts and feels a pop, non-contact. And these, ACL tears occur 3 to 7 times more frequently in female athletes than they occur in male athletes. Why is that? Nobody can tell you. They've looked at hormones. Are the ACL tears related to the menstrual cycle? Is it because females have more valgus knees? Is it because the quadriceps hamstring imbalance is more pronounced in females than males? The current thinking is that when females land, they tend to land with their knees internally rotated and their knees are more valgus, whereas men tend to land with their hips externally rotated and less valgus on their knees. So there's now this kind of jump training they're trying to do with female athletes and trying to teach them to land with more external rotation in their hips and less valgus in the knees. And there's some evidence to say that it's preventative, but we really haven't solved the answer. So what the person's gonna come in is like, I cut, felt a pop, fell to the ground, couldn't get up, my knee felt, or a lot of times people say, I feel like my thigh went one way and my shin went the other way. All those things are great stories. Like when I hear that story, I'm like, that's an ACL until proven otherwise. What's the only other injury it's probably gonna be? Patella dislocation. Remember that at the very beginning of the lecture? That's the only other thing that they probably will think about. And so the patients will, if you said to somebody, tear your ACL, of what's going to happen to them, right? Their knee is going to get better. The effusion is going to go away. Their range of motion is going to come back. They're going to feel pretty good. But if they go untreated, and I've seen untreated patients because they're stubborn and they don't go to the doctor or something like that, and they go back out on the field 5 weeks later or something, and now every time they cut and pivot, their knee gives out or feels like it's going to buckle, it's because they've lost their ACL. They've lost that rope that prevents the shin bone from coming out from underneath the thigh bone. And it doesn't come out a lot, but it comes out enough, and you'll see on some pictures. So this is just an example. This is important in terms of looking at the strength, at the tension, range of motion graph. Again, getting back to some basic science and biomechanics, but the ACL is tightest in the last few degrees of extension, from about 30 degrees to 0 degrees. It's a little bit looser when you're in knee flexion. Now, why is that important? It's because on the physical examination, there's two tests that you'll hear about for the ACL. There's the Lockman examination, which is this exam, where the knee is flexed about 20 degrees. You stabilize the femur with one hand, and you pull forward on the tibia with the other hand. And normally, if you think about, again, think of ligaments like ropes. If you pull on a rope real quickly, it kind of snaps taut. So when I grab the tibia and pull forward, I'll feel what we call a firm endpoint. That's in a normal knee. If someone's torn their ACL, the tibia comes further forward than it should, and I get what's called a soft endpoint. I don't get that tautness of the rope. Now, you can do the Lockman examination, which is what most orthopedic surgeons do, hopefully, but you'll read in the books about the anterior drawer. Well, how do you do the anterior drawer? That's easy, because the patient's lying in the exam table, you put their foot up, and you bend their knee about 90 degrees, and you grab the tibia and you pull it forward. Now, which of those exam findings, that's in a normal knee, if you do a Lockman or an anterior drawer, which of those exam findings is going to have more anterior tibial translation? I'm going to go back and graph. Where's the ligament looser? Inflection. So the anterior drawer is going to have more tibial translation than a Lockman. So why is it? So that it's on the test. They might ask the residents, which of the knee exams is more reliable for an ACL tear? It's the Lockman, because you're testing, you want to test your ligaments in their tightest position. So we're going to test the ACL at 20 degrees. Now the same will hold true, but in the opposite, if you're doing testing for the PCL, because the PCL has the opposite curve. The posterior cruciate ligament is tight in flexion and a little looser in extension. So if you do a posterior drawer at 20 or 30 degrees, the tibia is going to go back a certain amount, but at 90 degrees, it should go back less. So you always want to test for your ligament in its tightest position. So again, that's just an example of understanding like basic science, and why understanding basic science makes you a better clinician. It really does come in handy. So the first 2 years of medical school really are important. And then so X-rays are almost always negative. The one classic test question is if you see a small chip on the anterolateral tibia, that's called a Sagun sign, which is probably an avulsion fracture of the anterolateral ligament. That's pathognomonic for an ACL, but nobody relies on X-rays anymore. We get MRIs for hangnails, to tell you the truth. So we definitely get MRIs for an ACL tear. So what do I see on this MRI? Well, here's my femur, here's my tibia, and here's my ACL. You could almost argue that that's okay, but it's really not. Normally, ligament signals are dense black signals because they don't have a lot of water content, and that ACL should be going from the front of the tibia to the back of the femur here, and it should be a more distinct black line. But if I look at my T2 image, and on T2 images, everything's usually black or gray, but look at what I see, bone bruises. There's a bone bruise on the lateral femoral condyle, a bone bruise on the lateral tibial plateau. So you can tell what happened to this knee, right? The tibia went out, forward, and back into place. The back of the shin banged down to the front of the thigh bone, and that's why I have these bone bruises. So if I see this cut on an MRI, I don't even need to have to see that. I already know what the diagnosis is. ACL tear just based on bone bruise pattern alone. So understanding all these things is going to help you be a better reader of MRI, because I can tell you that I've had radiologists read an MRI like this and say ACL intact. But if you looked at the T2 images and saw these bone bruises, there's no way in hell that ACL intact. It can't be. You can't just get this bone bruise pattern without tearing your ACL. So what do we do for ACL reconstruction? Well, a long time ago, they tried sewing the ACL back together. That didn't work. So they abandoned that. We went to ACL reconstruction. So we can think about what can we use to reconstruct the ACL. Well, the workhorse of ACL reconstruction is the patellar tendon. Now, the patellar tendon is about 35 millimeters wide. We can take the central 10 millimeters of the tendon with a little bone from the patella and the tibial tubercle, route that through the knee arthroscopically. That's a new ACL. That's the workhorse. We consider the gold standard in 2021. But another really common choice are the hamstring tendons. Now we can take the semitendinosus and the gracilis, and we can take those without decreasing or sacrificing function of the knee, because what's left behind, the semimembranosus, which is a bigger, stronger hamstring tendon than the semitendinosus and wimpy little gracilis that's there. But we take those tendons out of the knee, and where do they attach? Well, you need to know anatomy. This is called the pes anserine. We go through the sartorius. Here's the gracilis. Here's the semitendinosus. We harvest those tendons. We put them into the knee arthroscopically, and that's your new ACL. And then there's another option, is use an allograft. So we can use an allograft, which is taking donor tissue and implanting that into the knee arthroscopically, and that's a new ACL. Now, do we have to use patellar tendon and hamstrings? No, because you can use any tendon you want from an allograft. I can use the tibialis anterior, the tibialis posterior. I can use the peroneal tendons from the ankle. They're bigger and stronger tendons than the hamstrings and the patellar tendon, but I can't use that as an autograft, because if I take your tibia tendon, you're not going to be able to walk because you're going to have a foot drop, right? So you can't take that as an autograft. But for allograft reconstruction, you can use it. It's nice because it's an easy recovery. You're not, as they like to say, robbing from Peter to pay Paul. You're not taking normal anatomy and using it to reconstruct or rebuild normal anatomy. So again, in middle-aged people who are done with their college careers, allografts have great outcomes. But if you do an allograft reconstruction in a high school or collegiate athlete, the re-tear rate is 30% higher than if you use their own autograft tissue. Why is that? We don't know the answer yet. Because those allograft tendons are stronger, substantially stronger than the autograft tendons we use. Is it rejection? Probably not, because they're not blood-filled organs. So there's not blood going through them causing a rejection process. So we really don't know the answer to it. Not a long time ago, but several years ago, one of the big issues was sterility. So they were saying, well, we'll just irradiate the allografts. But by irradiating the allografts, you disrupt all the cross-links in the collagen, and that weakens them and makes them more susceptible to enzymatic breakdown. So then everybody stopped irradiating allografts, but even with fresh frozen allografts, we still see a 30% higher re-tear rate. So if one of you can figure that out, it'll be great, because trust me, allografts are way better. I can do an allograft ACL reconstruction in like 25 minutes because I don't have to harvest the graft, but I have to take the time harvesting the graft, and then patients have graft harvest pain. So this would be ideal if we could do that, but it doesn't really work. As far as reconstruction or rehab after the surgery, let me just go back real quickly. A lot of what we do is to protect the ACL. So initially, patients are doing things like straight leg raises because there's no translation on the tibia. We get them doing on an exercise bike in about 10 days. They're doing squats and leg presses in about 3 to 4 weeks. They're running in about 8 to 10 weeks, but we don't let them go back to sports for a minimum of 6 months. And why is that? Both the patella tendon and the hamstrings, those grafts are as strong as the ACL. So the grafts are strong enough to withstand the rigors of sports. But when you put them into the knee, they have to be biologically fixed into the bones. And that biological healing takes a certain amount of time. The other thing is when you put the graft into the knee, it does go through a remodeling process. So the graft starts out at about 2,000 newtons, is as strong as a normal ACL. In the first 3 months, it loses about 50% of its strength, and then it starts to regain strength again. And the consensus is that it regains its strength at around 6 to 9 months, but it actually never regains its total strength. It probably only gets back to about 80% of its normal strength, and yet it withstands the rigors of returning to a career in professional sports. Why is that? Because ligaments in the body do have a safety factor built into them. Like, you don't, if your ACL was subjected to its ultimate tensile stress every time, every time you fell down the stairs, you tear your ACL. It's like certain maneuvers and certain things that cause it to pop, but we do have safety factors built in, and that's why you can survive at a lower level than the ultimate strength of the ACL. But as I said, one of the main reasons we could reconstruct the ACL is not only to prevent instability of the knee, but also those instability episodes. As you can see from that MRI, those bone bruises, don't you think that the cartilage overlying those bone bruises got damaged? Absolutely. So, you don't want to damage that cartilage 1,000 times. So by preventing the knee from giving out, you're protecting the articular cartilage, and you're protecting the posterior horn of your medial meniscus. And it's damage to those structures that lead to arthritis at a younger age than if you didn't tear your ACL. So if somebody says, and parents say this all the time, well, or older people who want ACL surgery say, I need an ACL reconstruction because if I don't have an ACL, I'm going to get arthritis. You're not going to get if you tear your ACL and your knee never gives out again in your entire life, you're not going to get arthritis any faster than someone who has an ACL. But if you tear your ACL and your knee's unstable and it gives out, you're damaging menisci and cartilage, and that's what causes arthritis. So again, as much as ACL, one of the main reasons for ACL reconstruction is to protect the integrity of the knee. And that's why we recommend it strongly in high school and college athletes for sure. PCL injuries, just so you know, this is kind of, again, not an uncommon test question, but when you tear your PCL, it's usually a fall on a plantar flex ankle. And why is that important? Well, this is kind of the theoretical mechanism. If the ankle is plantar flexed, you'll hit your tibial tubercle on the ground, and that'll drive your tibia backwards, and that'll tear your PCL. If your ankle is dorsiflexed and your toes hit the ground, you tend to land on your patella and you fracture your patella or just bruise your knee, but you don't tear your PCL. I know for some reason they ask that on the test a lot, so that's why I have a picture in there. And this is a bad X-ray, right? So this is a knee dislocation. And so I always tell the residents, the residents know this, but if you were in an emergency room, you don't need an X-ray to tell me that looks like that. Right? I'm telling you, you can look at that knee and it looks bad. And so what do? Well, if an orthopedic resident was downstairs and they saw this knee, they would grab the tibia and they would pull it really hard and pull it back underneath the femur as quickly as they could. Why would they do that? Like, why do you want to do that? Why not just wait 2 hours and get an X-ray and show that the knee's dislocated? What's going on? Where's our popliteal artery? Back here, down here, and then back up this way, right? That artery is unstretched. It might be torn. It's usually not torn, but it could be clotted off. You could cause an intimal tear, which could then lead to a blood clot. And now it's an emergency. What else is going on? Where's our perineal nerve? Our perineal nerve is here. Now it goes back up to the fibular neck and down there. That fibular nerve is perineal nerve is being stretched for 2 hours while you're waiting for an X-ray. So again, I don't call this an emergency, but someone who knows orthopedics better grab that leg and pull it back into place, because then everything's back into normal position and it's less damage to the surrounding structure. So if I show you this X-ray, what do you know? You know that the cruciate ligaments are torn, right? The ACL and PCL have to be torn. Can you tell me if the MCL or the LCL is torn there? How come? Because it's a lateral X-ray. You have no idea what's going on. I get my orthogonal X-ray. Which ligament's torn? Here's your fibula right here on the lateral side. The LCL, right? Because look how the space between your femur and tibia there. Your MCL is probably okay. I can guarantee your LCL is torn. Again, orthogonal X-rays. So do I need an MRI to tell me that I have an ACL, PCL, MCL, LCL? No, I need 2 X-rays, and I know the whole story. I can examine this knee once it's reduced. Obviously, the tibia is going to go in both directions. And if I valgus the knee, it's going to be stable. But if I varus the knee, it's going to open wide open because I've torn not only my LCL, but my whole posterolateral capsule. So again, I'll bust on the ortho residents of fracture comments. They'll say, well, we're gonna get MRI. I say, why do you need MRI? Just examine the knee and tell me what was torn. But you do need an MRI because you want to know if there's meniscus damage, you want to know if there's cartilage damage and things like that. But we've gotten to the age where a lot of clinicians rely on the MRI and forget about history and physical examination. And I'm old school enough that I still believe that the history and the physical examination are the most important part of taking care of a patient. Keeping that button. So knee dislocations, usually when we let the knee settle down, then we reconstruct all the ligaments. So it's a big operation, usually a 2 to 4 hour surgery. We just did a kid who dislocated his knee and he basically tore his peroneal nerve in half. So we tried to sew the peroneal nerve back together, but it probably won't work. They'll probably end up with a foot drop. So then they'll have to get tendon transfers or something like that later on in life. And this happens in sports. It happens in motor vehicle accidents, happens in high energy trauma. I took care of a kid at Rutgers who graduated, had a great job. On graduation night, went out to celebrate, got in a car accident, dislocated his knee. He ripped his peroneal nerve right off of the sciatic nerve. No chance for repair. And then, just unbelievable, devastating injury to somebody's knee. Luckily, they don't happen that often. No, I'm not going forward. Isn't that working? Maybe I can do this. Next. So I call these urgent reductions. You have to look for vascular injuries, peroneal nerve injuries. You repair and reconstruct, and it's a tough, long recovery, but patients tend to do okay. Not as great as ACL. So that's kind of a run through that from relatively mundane patellofemoral pain to the dramatic injury of a knee dislocation. These are things, the most of the stuff I covered, the patellofemoral pain, the meniscal injuries, the cartilage injuries, the ACL tears, PCL tears, that's office sports medicine type of orthopedics. Knee dislocations are emergency room sports medicine. So hopefully that was interesting. I tried to save a little time for questions, so I'll just open it up to questions.
First of all, thank you so much for coming. My knees are hurting just looking at all those pictures. But I did have one question. So when you were talking about the patellar dislocation, that it always goes laterally, how far can it go laterally? Like, what's the most extreme that you've seen? Like, would it go the whole way around, or like no?
Well, it's sitting. When it's sitting on the lateral femoral condyle. Go way back really fast, but I'll go to the MRI of the patellar dislocation. So. So here's your patella sitting here. It's going to sit right there on the side of the knee. So you just see it on the side of the knee. It can never go. It can't go back here. If the patella goes back here, you probably dislocated your knee at the same time. But it's usually sitting right there. A lot of times it's kind of perched right on the corner, just sitting right about there. But again, people like reflexively straighten out their knee, or someone who comes to their aid reflexively grabs their knee and straightens it out. And that'll pop it back into place. And that's an interesting thing about orthopedics. People say, like, I heard a few people cringe when I said, grab that tibia and pull it really hard and get it back under there. But think about it. If you were like out for a run and somebody was lying on the street and their tibia was bent 90 degrees, like, what would you do? Well, you'd straighten it out, right? You'd just like sit there and say, oh, I'm going to call an ambulance and leave your leg bent 90 degrees. Like, put things back to where they belong. You're not going to make it any worse. It's already bad. Just put it back into place. It's not rocket science, trust me. So, that's why, like, I've been on the football field and people sustain fracture dislocation of the ankle. The ankle's turned 90 degrees the way it is. I just run out of the field. The trainers cover the ankle up with a towel. And I go, and I pop it back into place. Nobody sees it because it's under a towel. And if you do these things right away, I had an athletic trainer call me one time, and her soccer player broke the tibia. She called me. She's like, "Oh my God, this tibia is bent. Like it's all cockeyed." I said, "Well, straighten it out and put a splint down." And they did it, and it was lined up pretty well. They're gonna be a lot more comfortable going in the ambulance with their legs straight and bent, like all crooked. So you're not gonna hurt anything. It's already hurt.
But what about a stubborn athlete that's like playing for a long time with persistent
No, you actually, so you don't. So let's say, and I've seen this a lot, so if someone comes in with patellofemoral pain and they have a large effusion, and I'll aspirate their knee, and I'll stick a needle in the knee and draw 30 cc of fluid out. That fluid is perfectly clear yellow. If I send it for a cell count, the cell count is 10. If I aspirate somebody's knee who's got rheumatoid arthritis or inflammatory arthropathy, and I send their knee aspirate for a cell count, it's going to come back 10,000 or 30,000. So even in that patellofemoral pain, they don't have inflammation in their knee. It's weird. You don't really understand it. I've challenged orthopedic residents to tell me why is arthritis painful? Like, why does arthritis hurt? Knee arthritis. Does cartilage have nerve endings? No. So the meniscus doesn't really have nerve endings. The cartilage doesn't have nerve endings. The bone really doesn't have nerve endings. If you look at, you can, like when we put traction pins through people's legs, we numb up the periosteum on the outer side of the femur and the inner side of the femur, or the lateral side of the tibia and the lateral side of the tibia. That's because as the pin penetrates the periosteum, they hurt. But as the pin drives through the middle of the bone, they barely feel it. And then when it comes out the other side, they feel it again. So there's not a lot of nervous innervation, even in the bone. And yet people complain of pain with arthritis. Physiologically, it's really challenging to explain why arthritis hurts. There's not a lot of inflammation. There's not a lot of nerve endings, and yet people are in such bad pain and get knee replacements. So go figure. I can't figure it out. You know, it's funny, because I was a chief resident, been in orthopedics for 5 years. And I'll be in office hours with me. I'll just say, tell me why arthritis causes pain. No, they'll all of a sudden they can't explain it. I can't believe that they're 5 years into residency and they don't know the answer. But I'm 25 years into my practice. I don't know the answer. Anything else? All right, cool. So, you know, again, I know there's a mixture of first and second years in here, but hopefully, you know, when you do your knee anatomy upstairs, you'll think of some of these injuries and start to think about, you know, how well this anatomy applies to your surgical exposures, your surgical procedures, but more importantly, at your level, how does anatomy apply to your physical exam and your history findings? You'll be a much better clinician if you understand anatomy well, because that's what orthopedics is restoration of normal anatomy. You have to know normal anatomy to treat or diagnose it or abnormal anatomy. You can't fix it if you don't know what it was like before it got old. Okay. Cool.
QR code for attendance, accounts for ORG and anatomy on site. If you don't have it, it's in the back.
Yeah, hold on, just make sure.
Oh,
I get it off.
yeah.
Yeah, I'll do that. Thanks so much for coming.
Sure. I'm gonna take my flash drive out.
Yeah. Let's do that first. I just pull it out. You want me to?
If you want, I don't, it doesn't matter to me, but I think sometimes if you just pull it out, it messes up you don't have to like eject it. So if you close the presentation first.
Should be down here.
Yeah. Okay. Hopefully that's it. No, thank you. Is that good for those levels? of
Yeah,
students?
that was great. The thanks so much. Yeah, I think the anatomy in the beginning was really good. And then like as they I'm sure we were understanding like more of the like technical terms, but as they go on, I'm sure it's just being exposed to it.
Right. That's the thing.
So
Just get more
important.
exposure.
Yeah, exactly. I might have questions.
Yeah. There's usually